Good morning, everyone. Welcome to today's webinar. This is the third in a series of webinars hosted by the National Collaborating Centre for Infectious Diseases on the topic of corrections as a public health setting for sexually transmitted and blood-borne infections. My name is Susie Taylor. I'm a project manager at NCCID, primarily focused on STBBIs, and I'll be your moderator. The National Collaborating Centre for Infectious Diseases is funded by the Public Health Agency of Canada to provide knowledge translation and evidence for use in public health planning and policy. We are hosted by the University of Manitoba, and I would like to acknowledge that our offices are on Treaty 1 territory, the homeland of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene people, and on the homeland of the Métis Nation. Before we begin, there's a few household items. The event will be recorded and it will be available on the NCCID website later on. There will also be a Q&A session at the end of the presentation, so you can use the Q&A tab, which is in the bottom of your screen there, to pose content-related questions to the presenter. We'll try to answer as many questions as time allows, but it is possible we won't get to all of them today. The chat will be disabled except for the host and the panelists so that they can share resources with attendees. And I would now, without any further ado, like to introduce today's speaker, Dr. Amita Singh, and welcome her. Dr. Singh is a clinical professor in the Department of Medicine at the University of Alberta. Her research focuses on sexually transmitted infections and HIV, particularly guideline development, program evaluation, prevention, and rapid testing. She was the Alberta Provincial Consultant for Sexually Transmitted and Blood-borne Infections from 1998 to 2008, and the Medical Director of the Edmonton STI Clinic from 1998 to 2014. She served as an HIV consultant for federal corrections at the Edmonton Institute for Women from 2000 to 2017, and she maintains a general infectious diseases practice at the Royal Alexandra Hospital in Edmonton and an HIV STI outpatient practice at the Edmonton STI Clinic. She's also served as a consultant to the government of Nunavut since 2017. So over to you, Dr. Singh.
Thank you so much, Susie, and thank you so much to NCCID for inviting me today to share with you some of our experiences with point-of-care testing and treatment for syphilis in provincial corrections. So I think Susie's already gone through this, but please use the question and answer tab to provide any questions. And if you like someone else's question and you think that should be answered, then click like, and that'll push them up to the priority. Before I get started, I would like to acknowledge that I'm located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, which include the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, and Inuit peoples. Just before we get started, my only disclosures are that I was the principal investigator and the medical lead for the point-of-care test for syphilis and HIV study in Alberta. And in terms of objectives today, we're hoping to share with you the importance of testing and providing treatment for STIs, including syphilis in provincial correctional settings, the findings of study using dual HIV and syphilis point-of-care tests in Alberta, particularly in a provincial correctional setting, and what we're currently doing with those tests. So before I get started, I'd like to go over a little bit of background. Although I know this is the third in the series of webinars, I thought that it would be important to set the stage for corrections in Canada, which I'm sure most of you know is a shared responsibility of federal, provincial, and territorial governments. Interestingly, if you look at this line here in Canada, it looks like the incarceration rates in Canada have essentially remained the same over time, but in fact, they have declined by about 8.6% over time. And if you compare the prison population per 100,000 with the United States, you'll see that even though the US has had also a decline in incarceration rates over time, their rates of incarceration remain among the highest in the world. And certainly, you know, I would like to say that I hope that one day we will be approaching the incarceration rates of Norway and Finland, which you see at the bottom of the slide. The other interesting thing to note when we're thinking about the possibility of delivering services in corrections is what is the length of stay? And if you look at this, you'll see that 63% of women are incarcerated for 1 month or less, and about 50% of men. So this is very important when we're thinking about delivering services. In addition to that, in between 2018 and 2019, 10 of 13 provinces and territories were in remand. So, weren't in 10 of 13 provinces and territories, about half of the adult population were in remand. And Indigenous adults accounted for about a third of all admissions to provincial, territorial, and federal custody, even though Indigenous persons in Canada represent only about 4.5% of the Canadian adult population. And this is even higher in the prairie provinces. So, for example, in Manitoba and Saskatchewan, 3/4 of all admissions to correctional facilities are Indigenous adults. So what about STIs in incarcerated adults? There's very good literature now showing us that STIs may be as high as 10 to 20 times higher incarcerated persons than among peers in the outside community. The high rates of STIs in corrections are driven by disparities in the social determinants of health and also structural racism targeting those who enter institutions. The prevalence of syphilis, of course, is also much higher in incarcerated persons, and it is really important to look at local epidemiology to help guide the testing strategies that are used in jail. So, for example, in California, where they have among the highest syphilis rates in the United States, one study reported that 13% of pregnant women who delivered an infant with congenital syphilis had been incarcerated. So, this highlighted the importance of trying to reach women in corrections to test them for syphilis. And the authors concluded that failure to test and treat women in jail is really a missed opportunity to prevent congenital syphilis. Both the Canadian and the US CDC guidelines recommend that syphilis screening be offered to all persons upon entry into incarceration. And although the US do go on to say that this should be offered based on the local area and institutional prevalence of infectious syphilis. What about opt-out versus opt-in screening? I know that a previous webinar was based on this, and there's no question overall that opt-out testing results in increased levels of screening. That does make sense, that if you make testing routine and you try to normalize testing and only offer people the option to opt out, that you're going to get more people accepting testing. However, interestingly, an Alberta study that was done between March of 2018 and February of 2020 showed that even though opt-out testing was offered to all inmates at a remand facility, about 1,600 inmates daily, only about a third consented to testing and 97% completed testing. Despite this very low uptake of testing, you'll see that in this very relatively short period of time, 146 cases of infectious syphilis were identified. So in Alberta, where we are experiencing an outbreak of syphilis currently, offering testing in corrections was very important to identify new cases of infectious syphilis. The problem with syphilis, though, is that the diagnosis is really quite complicated. I want to quote Dr. Peeling, who I'm sure many of you know. Dr. Peeling is Canadian, is now based at the London School of Hygiene and Tropical Medicine in the UK, and she has done a lot of work on syphilis and point of care tests for syphilis. And just to quote her, she said, "A perfect reference standard for syphilis does not exist." And so what we're stuck with doing is trying to put together a number of things to determine if somebody's newly infected or not. Among those things that we need to take into consideration are the person's past history. Have they previously had syphilis or not, and have they been treated? What were their prior test results? Do they have any clinical manifestations? But of course, the manifestations can vary and be quite subtle. What are the results of direct tests? So unfortunately, in contrast to other bacteria, the organism that causes syphilis cannot be viewed under regular microscopy. It does require something called a dark field microscope. And right now in Alberta, there are only 2 dark field microscopes available at the Edmonton and Calgary STI clinics. They require a fresh specimen, so a specimen collected within an hour of collection and put under the microscope, and also significant user expertise to use these microscopes. We do have syphilis PCR available in Alberta, but it's not available across the country, and there's often a long turnaround time to those results being available. Syphilis blood tests or serology are really the mainstay of diagnosis, but it requires a combination of tests, an algorithm, usually including 2 to 3 tests, depending on where you are in the country. So most labs in Canada are using what's called a reverse sequence algorithm for diagnosing syphilis. I don't want to spend too much time on this, but it is important when we think about point of care tests. So screening typically starts with a treponemal test, such as an EIA or a CMIA. And these tests are very handy for putting through large volumes of specimens in a lab. But if this test is positive, it is followed by a non-treponemal test, usually the rapid plasma reagent or the RPR. And the RPR is a very important test, which I'll tell you about shortly. And then often once the reverse sequence algorithm is being run, it is followed by a second treponemal test, such as the TPPA, to confirm whether someone really has syphilis or not. Now, the problem with these treponemal tests, such as the EIA, is that they remain positive for life and cannot distinguish between a new case of syphilis and a case of syphilis that is either old or has been previously treated. So just to run through these 3 different tests again. So the EIA, again, is the screening test. It arises during the primary stage and typically persists in most cases for the life of the patient. The RPR, after someone has been diagnosed with syphilis, becomes the most important test. So it is usually reported with a titer or dilution. So for example, the titer could be anything from non-reactive to reactive at 1 dilution to the highest I've seen is 8,096 dilutions, and that titer is a measure of disease activity. And we usually consider a titer of greater than or equal to 1 in 8 dilutions to be representative of active syphilis. Now, that's not a hard and fast rule, unfortunately. Again, these tests have to be interpreted together with all of the other information we talked about previously, but it is a really good guide. This titer is also what we use to follow the response to treatment over time and to determine as well if someone has been reinfected or not. The TPPA, which is the second treponemal test that is done the first time syphilis screen is found to be positive, is often considered to be a confirmatory test. So what about our study then? So in 2019, a syphilis outbreak was declared in Alberta by our Chief Medical Officer of Health amid a rapid increase in cases, and in fact, the worst since 1948. So Alberta and certainly Edmonton, which was the epicenter, had not seen such high rates of infectious syphilis since 1948. And so the question that was asked of us is, could point of care tests for syphilis help with our response to this outbreak? And so, the first thing that I said was we have to look at the epidemiology. And so when we had a look at our case is, I learned that an estimated loss to follow-up or significant delays in treatment were occurring in about 20 to 30% of all of our new syphilis cases. This was especially occurring in persons who were seen in the emergency departments, including our inner city hospitals and also at our remand center. And at the same time, we were seeing an incredibly high number of cases of congenital syphilis. This photograph here is a picture of one of our babies who, as you can see, has an incredibly enlarged liver and spleen. The liver should be up here, the spleen up here, a very severe desquamating or peeling rash, and also severe anemia. In 2019, in taking a look at our epidemiology as well, we also learned that Indigenous persons represented about 40% of all cases, females about half, persons who injected drugs about 20%, same-sex males about 20%, and about a third had one or more risk factors. Between 2017 and 19, there were also a horrifying number of congenital cases, 63 cases with 13 stillbirths, and 73% of mothers were aged between 20 to 34. So in 2019, there were more than 2,000 infectious syphilis cases in Alberta, with about 60% of the cases in Edmonton. So that led to the point of care testing for syphilis and HIV. This term POSH was coined by Jennifer Greatrix, the manager of our STI services. So we're going to call this the POSH study from now on, was done in Alberta. So our primary objective of the study was really a response to the syphilis outbreak in Alberta. We hoped that by using point of care tests, we could expedite testing so that treatment could be provided at the point of care visit. In terms, because there were no Health Canada approved point of care tests, we set this up as a research study with our research objectives being primarily, number one, to assess the test performance of two different dual point of care tests for HIV and syphilis, using finger stick whole blood specimens and comparing it to our standard tests that we did through serology, to determine the linkages to care for both HIV and syphilis, and to evaluate the patient and test administrator experience with POCT. Since there were no Health Canada approved tests in Canada, we also hope to collect the data and provide them to both companies whose tests we were using through the use of what's called an investigational testing application, so that the companies could use the data to submit to Health Canada for consideration of licensure if the tests were shown to be effective. So who did we enroll into the study? Participants had to be at least 16 years of age and undergoing routine testing for STI and HIV. We included 5 clinical sites in Edmonton and Northern Alberta, our STI clinic, and of course we hope to use to include our outreach team and services. The pandemic put the brakes on that. 2 inner city hospital emergency departments, 1 First Nations community. We originally started off with 2 communities, but 1 withdrew from the study shortly after the start of the pandemic, and then a provincial correctional facility. We evaluated 2 different tests, and you'll note that both of these tests happen to be made by Canadian companies. The INSTI multiplex test and the multiplo rapid TP HIV tests. So nurses did all of the testing, and participants provided finger stick whole blood specimens, and we also required that they have parallel serum specimens collected to test for HIV and syphilis. So these are the 2 tests that we use, and I'm going to show you videos of those shortly. So the first one is the MedMira test, and I'm going to skip through this, but I want to just show you the highlights of how the test works.
MedMira in development. Rapid. The following demonstrate HIV. Everything needed to conduct any study, including.
So this is what the test kit looks like when you open it up. You'll see this is the actual test kit here. These are the 2 buffers.
Finger stick hold. For collecting, unscrew the white cap of vial 1. Using the alcohol swab, clean finger. Allow the finger to dry.
Now, this is how you actually collect a finger stick whole blood specimen. It looks like it is an easy thing to do, but unfortunately, there was a bit of a learning curve for us when we started learning how to collect the finger stick whole blood specimens. But this just shows you how the process is done. So the lancet is used to provide a prick on the finger, and then the finger is massaged to form a drop or bead of blood.
The autofill pipette. What? Not squeeze the bottom of the pipette. Touch the tip to the pipette.
So the pipette is just touched to the blood, and you keep doing that until the pipette fills with the bead of blood. So ideally, you want to sort of collect the blood until it reaches the top of that pipette. Then it's
into vial 1. Inserting the autofill pipette into the vial and squeezing the top of the pipette.
so the blood is then squeezed into that first bottle. And this was very important with the MedMira test, is that is tapping the vial to make sure that the blood lyses. So you want to see that solution turn clear. Then the cap is removed from the test kit.
Pour all of the specimen onto the center of the test cartridge.
And the specimen is poured onto the test kit. So that test kit is then watched until all of the specimen runs through.
Now, place the blue plastic cap on the center of the test cartridge.
Then the blue cap is replaced over the top of the test cartridge.
Unscrew the black cap of vial 2 and pour the entire contents of the vial onto the center of the blue cap.
And the second bottle is taken, and that solution is now poured into the test kit. And you have to wait until that goes through again. Then you remove it. And after all of the solution goes through, then you can read the test. So the C here stands for control, and it's very, very important that that control line is visible on every test. Otherwise, the test is considered invalid. And if there is a clear dot on this side, then that's a positive HIV test result, and TP, it's positive for Treponema pallidum. You see the dot on that side. Okay. So I'd like to just show you the second test now, which is a little bit faster. So this is the test provided by Biolytical, which is based in Vancouver.
Syphilis, producing results in as little as 60 seconds. The test procedure is simple, and the test kit contains all the components required for testing. Package insert, membrane unit, lancet.
So this is the test kit. These are the contents of the test kit. Again, that's the actual test kit. Has 3 bottles. And it comes with the pipette, the lancet, and an alcohol pad. So you'll see that the test does need to be stored within a specific range of temperatures.
Familiarize yourself with INSTI and become familiar with universal precautions. INSTI is intended to be used.
Okay, so I'm going to just take you to how you actually perform the test. You can put the patient identifier there. So we've got the test is approved for use with finger stick, whole blood, venous blood, plasma, and serum. So again, you collect the specimen and fill the pipette. I won't take you through how you do that again. So again, you get that bead of blood, collect the blood.
However, if squeezing the ball
Now the blood is put into that first buffer and it is mixed and then put into the test kit.
Step number 2.
After that is absorbed, then the second buffer is put in.
Mix the solution thoroughly.
And then the third one, which is the clarifying solution.
To provide more contrast to the spots and facilitate.
The result is read immediately. And again, this is a little bit different. You'll see that this is the control dot on the test kit for INSTI. So a non-reactive result would just show the control spot alone.
Should appear. The control spot indicates the test has been performed correctly and the human specimen has been used. Reactive result.
If there's an HIV result, then you see a blue dot at the 6 o'clock position. And if that one is positive, then it is a preliminary HIV positive result. And it becomes a blue dot at the 9 o'clock position if it is a syphilis positive result. If both are reactive, then you get, of course, all 3 dots there. Okay, so, you know, I want to just talk about how we went about selecting those test kits. So there are probably hundreds of test kits on the global market. But based on a previous study that we did in Alberta a little bit more than 10 years ago, where that test kit took about 30 to 40 minutes to perform in the field. What I went looking for this time was a test kit that could provide results in 5 minutes or less. And I came across these 2 Canadian companies that made these 2 tests. And Biolytical makes the only Health Canada approved HIV point of care test. And I thought that that would be a good thing as well, because the field staff in Alberta were familiar with this particular test kit. We were a little bit concerned, however, that there was a very limited field data that was done at the time for both the Biolytical as well as the MedMira tests. And if you look at the sensitivity overall, it was quite low, 56% for the Biolytical test and 73% for the MedMira test. But for both of these test kits, when the RPR titer was greater than or equal to 8 dilutions, the sensitivity increased dramatically to about 80% and as high as 95% with the MedMira test. So then we took a look at all of our syphilis cases in Alberta in the year preceding the study, and we saw that more than 70% of the Alberta cases had RPR titers at greater than or equal to 1 in 8 dilutions. So it seemed to make sense that using these test kits could potentially help us. So what did we do then? So the other thing I mentioned to you before is that treponemal tests remain positive for life. And of course, both of these point of care tests are treponemal tests. So it's really important to be able to access people's prior treatment information to determine if they'd been previously syphilis positive or not. So testing was done by nurses who could either directly access STI services databases because they worked for STI services, or we ran the study during business hours when nurses, for example, in the emergency departments or First Nations communities could phone Central STI services to determine if the person had previously tested positive or not. So indications for treatment remain that if they were sexual contact to syphilis, had signs or symptoms suggestive of syphilis, they would continue to receive treatment. And in addition to that, if neither of those 2 criteria were met, but if they had a positive test result for syphilis, they could also be treated. So of course, we were going to be comparing those test results with standard testing. And ethics approval was obtained from the University of Alberta Ethics Board. And so, of course, what that meant is that there were also consent forms that we needed to review with every potential participant and to obtain either verbal or signed consent to proceed with the study. So we were able to include 1,500 participants, and we included participants who were previously known to be HIV positive or previously syphilis positive, because we actually wanted to see how the tests would perform in both of those settings as well. I've already talked about the participating sites. So what about the results? So I have to tell you that when we set up the study, we did not anticipate that the vast majority of testing would actually be done in corrections. We had thought that most of the testing would be done at the Edmonton STI clinic and through the outreach services, but unfortunately the study started just after the pandemic started, and the outreach services were essentially shut down. Movement through the STI clinic was very limited, and we had an amazing study coordinator who's one of our part of notification nurses who was doing this testing in correction, and he Noel Ives, and he pretty well single-handedly did most of the study in our correctional remand facility. Half of the participants were men, and you'll see that the majority were aged between 26 to 35 years. We had hoped to enroll more pregnant women, but in fact, only 12 pregnant women were subsequently enrolled. And although the numbers were too small to confirm this, they did not appear to be any difference in the test performance in those pregnant women. So this is a very complicated slide, but I want to draw your attention to the red circles here. If we look first of all at HIV, you'll see that the sensitivity for both tests was pretty close to 100%, and the specificity, again, 99+%. If we look now at the specificity for both tests was also very high, and the sensitivity when the RPR titer was greater than or equal to 8 dilutions was also very high, 98% for the multiplo test and 97.9% for the INSTI test. Both of the tests were much less sensitive when the RPR titers were less than 8 dilutions. You'll see 90% here for the multiplo, 78% for the INSTI test. And if the RPR was non-reactive, sensitivity fell to 50% for the multiplo test and 28% for the INSTI test. So bottom line is the tests work really well for active syphilis. I also wanted to share with you that we did see some false positive tests. I'm sure that most of you know that there is no such thing as the perfect diagnostic test. So with any test, we should expect to see both false positives and false negatives. And but of course, you know, this can be very traumatic for both the providers performing the tests as well as the participants. And so it is important to know that and to make sure that the personnel doing the testing are trained to respond to these positive test results. And for example, to discuss that these tests are preliminary test results and that we do need to wait for confirmatory test results before continuing to provide any action based on those test results. So what about our actual results? So 24 participants tested positive for HIV, of which 4 were newly diagnosed as living with HIV and 20 previously diagnosed. All participants were linked to HIV care. And of the participants who were tested positive, about a third of participants tested, so a third of the 1,500, so just under 500 participants tested positive for syphilis. And you'll see that of those, 202 were new infectious syphilis cases, and about 24 were non-infectious syphilis cases. And the vast majority of those infectious syphilis cases, so 87%, were treated at the same time as the positive point of care test. Point of care testing was also used to expedite part of notification. So Noel shared with us one of his experiences where he tested a male inmate and learned that his female partner was pregnant and was able to expedite testing and treatment for that female partner. So it is a very useful tool. We also asked participants, what they thought about the test, and 98% said that they would consider using future point of care tests. Other comments were that they thought it was innovative and a good idea. It was speedy, made the tests more acceptable and convenient. And some felt that on-the-spot test results might encourage people to do more frequent testing. We had 9 test administrators doing between 1 and 1,300 point of care tests. And the majority felt that the test instructions were either excellent or very clear and easy to use. And administrators noted that because you could have results immediately, that could lead to immediate treatment, reduce the loss to follow-up, provide opportunities for patient education, linkages to other supports, and also increase partner notification. So to summarize the POSH study then, both point of care tests for syphilis and HIV performed very well for active syphilis with RPR titers greater than or equal to 8 dilutions, and for HIV. Both tests resulted in a preliminary test result in under 5 minutes. They were both easy to perform and were acceptable to both the test administrators as well as the participant. But we continue to have some challenges that these tests do not distinguish between old syphilis and new syphilis. So I think there really does have to be a process in place to determine whether treatment will be offered or not, based on either having access to prior treatment information or simply accepting the trade-off that you may overtreat people who do not have a new case of syphilis. Is there any harm in doing that? Not really. The treatment is with most cases of syphilis are treated with a single injection of penicillin. Most people can be treated with injections of penicillin quite safely. There's a very rare chance that, of course, there could be an adverse event or such as anaphylaxis to the penicillin. And of course, you may inflict some pain related to the injections. The other thing that may happen, of course, is anxiety related to the false positive results. But I think with proper training and processes in place, that all of these issues can be addressed. So what about now post-POSH use of the syphilis point of care tests? I can tell you that one of the 2 companies has already submitted an application for expedited approval to Health Canada. How long is that going to take? We're being told it could take up to 6 months, possibly longer. So that's all that I know at this point. For now, however, both tests can be used by submitting an application to Health Canada's Special Access Program. And in fact, in Alberta, we're continuing to use the tests under Health Canada's Special Access Program. Dr. Smichek, who's our Provincial STI Medical Director, has submitted an application to Health Canada under SAP. And the tests are currently being used by STI services RNs to offer testing. We're continuing to offer testing in a provincial remand facility at the Edmonton STI clinic and by partner notification nurses in other parts of the province. So training is ongoing to help to facilitate that. Noel, this is a picture of Noel here, and myself also went up to the Northwest Territories in the middle of July and to train some of the nurses there. And Dr. Candola is leading this initiative, and we're really hoping to see the Northwest Territories start to do point of care testing soon. So before, I want to sort of wrap up here by discussing a little bit, why on earth are we not using syphilis plus or minus HIV point of care tests more widely in Canada? So I was, as part of my literature review recently, I was intrigued to see this study published in Sexually Transmitted Diseases in 1997, talking about new approaches to syphilis control, finding opportunities for syphilis treatment and congenital syphilis prevention in a women's correctional setting. And now they were using a very old syphilis test, using an RPR, stat RPR test, to offer testing and treatment to women in a correctional facility. But despite using a less sensitive test, they were able to demonstrate an overall increase in the number of inmates who were appropriately treated with a minimum amount of overtreatment in that facility, and concluded that this protocol may be applicable in other high-risk transient populations. So there you go. We know that these types of tests have been around for at least 2 decades. And interestingly, in 2021, this paper here summarized, did a systematic review and meta-analysis of syphilis point-of-care tests. And there were 9 studies, you'll see here from the countries listed here, that all but one were done in resource-limited settings. Most of them used finger prick whole blood specimens, and all testing was done by health personnel. And all of the point-of-care tests that were included in this study detected treponema-specific antibodies. But what we see is that the sensitivity of finger prick whole blood does vary by test from 0.67 to 0.97. Serum is obviously better. And if you use you'll see that the overall sensitivity here is about 85%, but very high specificity across the board for these tests. So the point of care accuracy does differ by study setting. And again, you know, we can expect to see false negative rates of about 14% with a range up to 21%, and a false positive rate on average about 2%. You may well ask, why is it that we don't have dual syphilis tests, or our current syphilis algorithms currently use both treponemal and non-treponemal? The non-treponemal tests, again, are the RPR. And so why don't we have point of care tests that can do this? So in fact, there is one such test kit on the market, the ChemBio test. I can tell you that I have been helping to evaluate this test together with my colleague, Dr. Yansoni at McGill in Nunavik and Nunavut. And the observation based on the preliminary data so far is that unfortunately, this test does not do as well with finger stick whole blood specimens. It does very well from serum. And so it also takes quite a long time. The company says 15 minutes, but in fact, by the time you've gone through all of the procedures, it takes probably more like 30 to 40 minutes. And it's perhaps better suited to doing in on-site labs, such as we were doing in Nunavut and Nunavik. The correlation as well of the non-treponemal test with the RPR is really not that great. And so there is still a long way to go before we have point of care tests that can adequately assess the RPR titers. So again, in Canada right now, there are no Health Canada approved tests for syphilis. There is a single HIV test that has been approved, and that has now recently been approved for home testing. The resurgence of infectious syphilis across Canada in the last few years in populations that could benefit from POCT by enabling a single visit for point of care testing and treatment. So I'd like to conclude there by saying that STIs, including syphilis, are very common in incarcerated persons in many parts of the country right now. In the POSH study, 2 dual syphilis and HIV POCT demonstrated excellent performance from finger stick whole blood specimens, with much better performance with active syphilis, with the RPR titers greater than or equal to 8 dilutions. And syphilis POCT may be particularly useful in corrections due to the short length of stay to enable single visit testing and treatment. I'd like to conclude by acknowledging our funders, the CIHR Center for Reach Nexus at MAP Center for Urban Health Solutions, the Canadian Foundation for AIDS Research, Indigenous Affairs Canada, Alberta Health Services, as well as Alberta Health, and also our many, many partners without whom the POSH study would not have got off the ground, and in particular, our amazing study coordinator, Noah Lives, and Jennifer Graytrix, who's helped us at every step of the way. So with that, I'd like to end and ask if anyone has any questions. I'm going to stop as well as sharing my screen right now.
Thanks very much, Dr. Singh. So if anyone has questions, just a reminder, you can use the Q&A tab at the bottom of your screen. And maybe I'll, oh, do we have one there? No, so we don't have one yet, so I'll just kick it off. One of the questions that I had was just, I'm interested in knowing a bit about your experience and kind of recommendations for getting buy-in from medical staff who work in corrections to use point-of-care tests, whether you can kind of comment on what that experience was like, or any kind of strategies you have for kind of encouraging people to look into using these methods.
And that's a really good question. So, you know, we had a very good advocate for doing these tests with Noel. So he's our pardon notification nurse for corrections, and I think that in his experience in doing the testing in corrections made him realize the utility of doing it. And so he has been doing a great sales job, if you like, of making the case for doing this. And I think that if people recognize how it can, in fact, you know, I think everyone's overwhelmed, got tons of responsibilities and things, competing priorities. And so, of course, you know, if we have designated STI staff, they, you know, this is their priority, and they can definitely recognize how this can reduce future workload by not having to bring people back for treatment. And also how, particularly for pregnant women, I think this will be a really useful tool, and expediting pardon treatment as well. So, you know, one of the complaints that we got and continue to get is that people get tested and then they're lost to follow-up. Well, in theory, in this type of situation, and especially because the tests are so quick to perform, but you know, part of this as well is providing adequate training so that staff know how to respond to the preliminary positive, the preliminary negative, and how to work through the complexities of trying to interpret whether someone should or should not be treated at the time of the positive test.
That's great. Thanks very much. Yeah, it's an interesting kind of challenge, because you're trying to kind of ask people in a certain sense to be able to manage the that initial diagnosis piece when it may not actually be when it may be a false positive. So
that's right. Yes.
Yeah, a bit challenging. Are there any other questions? We have one here. What is the alternative treatment for patients who are allergic to penicillin for syphilis?
So that's a good question. So for non-pregnant women or for non-pregnant persons, the alternative is with doxycycline, which is given orally twice a day for 14 days for infectious syphilis. Of course, we always really worry, though, when using oral doxycycline that's, you know, administered twice a day for 14 days, that people will not adhere to that treatment course and might not finish the course of treatment. So there, you know, a few years ago, there was great excitement because there was a study looking at single-dose azithromycin for the treatment of infectious syphilis, and showed that it was very effective at treating syphilis, early primary syphilis or incubating syphilis. But unfortunately, within a few months, the organism developed resistance to azithromycin and had to be withdrawn from the treatment guidelines. So at this point in time, we have no single oral therapy. And that's definitely a research priority, I know, for investigators who are working in this area to try to figure out, is there something else that we can use? Unfortunately, for pregnant women, there really is no good alternative, and they often, we usually recommend that those women be desensitized and then treated with penicillin. So desensitization involves having to give progressively higher doses of penicillin. So you start off with a really tiny dose and you give them higher doses every 15 minutes and monitor them. And at the end of 4 hours, they're given an injection of penicillin. This all has to be done in a hospital or a supervised setting. So it's quite labor intensive and time consuming as well.
Thanks, Dr. Singh. One question that brought up for me, could you comment a bit? You mentioned there were some pregnant women in this study. What is the handoff process with when the infants are born? Is there a kind of work with the pediatric infectious disease specialists at that point?
Yes. So we have a very detailed procedure in Alberta. All cases are all cases of syphilis actually are reviewed or managed together with a partner notification nurse, and all pregnant women with an STI, either with the medical director or with another STI consultant. So recommendations are actually made for the pregnant woman for her follow-up, including retesting at the time of delivery. And for infants born to mothers with infectious syphilis during pregnancy, a recommendation is made that the infants are assessed by pediatric infectious diseases specialist or in consultation with a pediatric infectious diseases specialist.
Great, thanks. Any other questions?
Everyone's being very quiet. Don't be shy. Please ask any questions if you have that, or if you would prefer to email me after, that's fine as well. I can put my email address into the chat here.
Thanks. Well, hearing no further questions, I think we'll just conclude. And again, I wanted to thank you very much, Dr. Singh, for joining us today.
It's my pleasure. Thank you for having me.
Yeah, it was a really interesting webinar. I appreciate it. So for the participants, please do complete the short webinar evaluation when you leave. It'll pop up as you leave Zoom. And just a reminder that the recording and the slides a link will be emailed out to everyone who registered through Eventbrite. It'll also be available on the webcast section of our website shortly after the webinar. So thanks again, everyone.
Thank you.